Hello, I'm Kathy Antela, Vice President of Education at the Immunodeficiency Foundation, and I would like to welcome you to the session about WHIM. And during this session, I would like you, please remember that the information shared is not intended to be medical advice to take care of yourself or a loved one. And whenever you're experiencing medical issues, please contact your healthcare provider. Now, at this time, I would like to welcome our wonderful presenter, Dr. Jolan Walter from the University of South Florida and Johns Hopkins All Children's Hospital. So thank you, Dr. Walter, for joining us today. And we are looking forward to learning and asking you questions.
Thank you, Kathy, for the kind introduction. I'm really excited to talk to you about WHIM syndrome. And for full disclosure, I have been working with several pharmaceutical companies, including X4 Pharmaceuticals, who have medications for WHIM syndrome. So a brief overview of the syndrome itself. WHIM is actually standing for an acronym called WARTS, Hypogammaglobulinemia, Infections, and Myelokathexis. And we will detail these features in the following slides. But overall, this is a syndrome of an inborn error of immunity when the CXCR4 receptor, as you can see it here, nicely crossing the membrane of the cell, has a gain of function mutation. And gain of function means that the receptor keep on firing and not let the cell to cool down. And it will be very sensitive to this interaction between CXCR4 and its ligand CXCL12, which will result in alteration of immune cell homing, in particular the exit of the neutrophils from the bone marrow to the periphery, and cell signaling. We have 11 known pathogenic mutations to date reported in the literature. And there is a very unique genetic testing that we can perform to find patients with WHIM syndrome. However, there is no approved targeted therapy for the disease. Furthermore, the syndrome itself is quite heterogeneous, even within the same family. Warts are only occurring in 50 to 70% of the patients. I will show you data that these features are not coming until much later in life. The patients can have low immunoglobulin levels, recurrent infections is as high as 95% of the cases. But what has been the most unifying clinical feature is actually myelokathexis. Myelokathexis is a Greek word for showing that the neutrophils are over-maturing. On the left side, you can see an apoptotic neutrophil with several nuclei, and they are connected by these thin filaments that can sometimes distance the nuclei from each other. The bone marrow has several of these neutrophils. However, in the blood, the neutrophils will be missing. This is a very complicated diagnosis, and it is operator dependent. As I mentioned to you, not all patients present with all these 4 characteristics at a given time, and patients can also have additional manifestation of the disease. So WHIM syndrome itself is a genetically inherited disorder. Therefore, when it is diagnosed, it is always recommended for patients to have the rest of the family screened. Because of the autosomal dominant inheritance, even one parent can pass it on to the next generation, as you can see it on the right. Every generation can be affected, and children of patients with WHIM syndrome have 50% chance of inheriting disease. There is, however, no good genotype-phenotype correlation, which means that just by having the gene is not predicting what type of clinical features a patient will have. As I mentioned, this prolonged CXCR4 signaling on the leukocytes will have a significant effect of how neutrophils and other immune cells move around in the body. In particular, with the increased signaling, CXCR4 positive WHIM neutrophils will not leave the bone marrow, and they will accumulate in the bone marrow, as you can see on the image on the right, and there will be much less of them in the periphery. That will result in a finding called neutropenia, and the neutrophils will also die with apoptosis. The accumulation of mature neutrophils, lymphocytes, and monocytes in the bone marrow have a very unique histological finding, but sometimes it can be mixed up with myelodysplasia. And again, dependent on the pathologist who is reading the slide, it can also just fully missed. The cellular immunopathogenesis of WHIM syndrome has several immune cell types included. Although most of our patients are taken care of by hematologists who follow neutropenia, it is increasingly recognized that both low T cells and B cells are significant component of the disease. B cells in particular are responsible for the antibody production, and therefore hypogammaglobulinemia could be a direct effect of the B cell lymphopenia and dysfunction. T cell lymphopenia also can contribute to infections, in particular viral infections and possibly warts. And T cell lymphopenia can also have some role in immune dysregulation or even cancer. Monocytopenia is the fourth cellular line that has been described in WHIM syndrome. So why do we call it a multi-system clinical disease? Well, first of all, as I have mentioned, several immune cell lines are affected. So the patients can have leukopenia, low lymphocyte count and white blood cell count, neutropenia, and also as an effect of that, they can have impaired vaccine responses and low antibody titers. And this all result in a compilation or complications of infections, such as EBV-associated disease, recurrent sinopulmonary infections, inflammation of the skin called cellulitis, and most importantly, treatment-resistant warts, which I believe is one of the major complications that could cause poor quality of life for our patients. Furthermore, WHIM syndrome patients have also been noted with periodontal infections. If the syndrome is unnoticed and not brought to the clinician in time, we can sometimes find our patients with long-term life-threatening consequences, such as sepsis, lymphoma, squamous cell carcinoma, and bronchiectasis, that is an end organ damage of the lung with dilation of the bronchial tree. Even children who are unnoticed and not treated well could end up with hearing loss since they have repeated ear infections. So what we have learned about warts is, again, warts are only appearing in half of the patients, and they could be in several parts of the body, including the skin or even the anogenital area or the oropharynx. And the patients who are having skin warts could potentially also develop other complications such as cervical dysplasia and eventually carcinoma. So they have to be monitored regularly for these complications. Hypogammaglobulinemia is very close to my heart since I work on B cells. And what we have seen that patients can have different level of antibody deficiencies. Some of them would have low IgG, but sometimes it's a combination of low IgG, A, and M. However, the impact of hypogammaglobulinemia on infection susceptibility is still quite unclear. So it's not uncommon that our patients would not start on immunoglobulin replacement therapy. And especially in the hands of the hematologist, sometimes I see a bit of a delay and hesitance to initiate these treatments. However, we know that in larger cohorts, up to 70% of the patients can develop hypogammaglobulinemia during their lifetime. Interestingly, recurrent infections, especially pneumonia, is an important feature of the disease. And again, the other parts of the body, such as ear, skin, oral cavity, and the sinopulmonary tract could all be affected. And the infection often begin in infancy and may lead to persistent life-threatening complications. And to me, infections is actually something that I would like to focus on in my talk as a pediatrician, somebody who would like to prevent this disease to progress. Infections are hard to dissect in a young child. And in this population, the combination of neutropenia with the infection could be a leading sign to consider WHIM syndrome. So here we are again, myelokathexis. I get a lot of questions from our patients and families on this condition. It's a hard diagnosis to make from the bone marrow of the patient. Again, you can see on the right, there is an accumulation of mature neutrophils with cytoplasmic vacuoles and pycnotic nuclear lobes that are distant, and they are connected with these tiny lily-like thin filaments. The concern is that myelokathexis, although it's the most important histological feature of the disease, it's hard to diagnose. First of all, bone marrow is not often performed because it's invasive and not necessary for the diagnosis. And even if when it is performed for patients, proper interpretation may be lacking as the process is highly operator dependent. I have seen several centers where the pathologists are not familiar with the syndrome and the bone marrow is interpreted differently, such as myelodysplastic syndrome or pre-malignant condition. So looking at the guidelines currently, how can we actually diagnose this syndrome? The European Society of Immunodeficiency came out with some recommendations. They recommend that if a patient has chronic neutropenia, less than 500, in combination with myelokathexis, the retention of neutrophils in the bone marrow, if you have a patient who have these two findings in combination with, on the left, chronic warts, lymphopenia, low IgG, or a parent with neutropenia, that could be making the diagnosis probable. However, if you actually do the genetic testing and you find a pathogenic variant in the intracellular part of the CXCR4 gene, then the diagnosis becomes definitive. And this is a key message of my talk here today, that the definitive diagnosis do require genetic testing. And I find it as a very informative and important measure that we should do as early as possible in these families. Furthermore, what we have just recently seen is that newborn screening has highlighted that TREX, the candidate biomarker of newborn screening first kit, could be low in WHIM syndrome patient. In fact, in a recent publication, we have shown that 6 patients who were born during the newborn screening era here in the US, of these 6 patients, 3 of them had low TREC levels. And the only infant who had normal levels of neutropenia was the one who had active infection. So we think that when you have an abnormal TREC quantification on newborn screening, in combination with a neutropenia, could be leading the clinician to think about WHIM syndrome. And this is a novel finding, and it shows the value of newborn screening first kid that could lead potentially to diagnosis of other disorders. So let's talk about the natural history of WHIM syndrome based on our preliminary data that is currently under review. We think that in WHIM syndrome, there is both an overactive and an underactive immune system. And this is a very large international collaboration of several centers around the world, as you can see it on my figure on the left. And currently we have 65 patients, and our list is growing every week. I would like to emphasize that our cohort was segregated to 2 different groups. In blue, I'm highlighting the one who had family history or newborn screening positive test. So these patients were identified very early in life. Whereas on the pink side, we are highlighting the patients who were only diagnosed with WHIM syndrome based on their clinical presentation. And many of the features were similar between the 2 groups, except infections. What we have noticed is that patients who had family history or were found in newborn screening tend to be recognized with infections earlier than those who actually were diagnosed based on clinical sign, which make me wonder if the clinical sign group was actually not, the infections were not taken as seriously as the family history group. And in fact, what we have seen that patients who were diagnosed at less than 1 year of age were very closely monitored. And they were diagnosed with neutropenia by as early as 6 months of age. You can see in the red arrow that 90% of our patients by 6 months of age were already diagnosed with neutropenia, whereas patients who were not diagnosed early in life and they were just diagnosed later, they did not have a documented neutropenia only in half of the patients by 6 months of age. So that tells us again that early monitoring and vigilance can really bring out the recognition of clinical features in this population. And what we really concluded from this study is that in pediatric patients, WHIM syndrome were not present with the typical tetrad of warts, hypogam, infection, and leukopenia, but infection and leukopenia will be dominating the picture, whereas adult patients will have more of the typical tetrad pictures of warts and hypogammaglobulinemia with the infections and leukopenia. And in both groups, performing genetic testing for CXCR4 could be a fast and easy way to confirm the diagnosis. We also noted this interesting feature that patients actually had autoimmune manifestations, and that has not been described in the past. As expected in most immunodeficiencies, cytopenias are the most common autoimmune manifestations, and in our patient population, 70% of the patients who were found with autoimmunity had cytopenias, followed by endocrinopathy, skin disease, hepatitis, and arthritis. And the cytopenias most of the time were at least double in age or even triple in age. What we think is happening in WHIM syndrome is that morbidity is also multifactorial. I have mentioned to you how many different cell types are involved in the disease mechanism, including the B cells, the T cells, the neutrophils, and the monocytes. So when we look at morbidity and mortality, the warts are definitely a major component of morbidity and mortality. And cervical dysplasia, carcinoma, and oropharyngeal cancer are all major manifestations that we have to monitor our patients for. However, hypogam and infections together can also lead to a significant end organ damage, such as bronchiectasis and hearing loss, as I mentioned in the previous part of my talk. Again, malignancies, I can't mention them enough, is extremely important to be monitored for. We believe that using the Gardasil HPV vaccine may be able to help to fight some of these complications, but at this point, we don't have enough evidence to make a direct conclusion. In the French severe neutropenia registry, the risk of cancer was relatively high, and it was dependent more on the genetic defect. However, we cannot conclude every risk factor for the cancer group yet based on larger studies. So how are we managing WHIM syndrome currently? As I mentioned to you, there is no definitive therapy approved for WHIM syndrome at this point. However, the patient experiences significant disease burden, and therefore we need to treat them. So most of our treatment are symptomatic and unfortunately not systematically evaluated. And we also have not had generated data how to effectively prevent or treat HPV-associated warts. So I am listing just here a few of the different interventions we can offer. We can use antibiotics for acute infections, or even for with low dose macrolides and inhaled aminoglycosides, we may be able to improve the risk of bronchiectasis exacerbations. Antiviral infection could be effective against recurrent herpes infections, and as expected, immunoglobulins may reduce the incidence of recurrent infections. However, it is not specifically approved for WHIM syndrome by the FDA. And lastly, not uncommonly, patients may get G-CSF therapy. This granulocyte colony stimulating factor can increase transiently the level of circulating neutrophils, but there have not been well-controlled studies documenting the efficacy of this treatment. And again, G-CSF is not specifically approved for WHIM syndrome, however, used off-label regularly. So I would like to take just 1 second to review with you novel treatment approaches that are currently in research phase for CXCR4 antagonists. As you can see in the left, this Lily-like receptor that is spanning the membrane and firing very, very hard to the middle of the cell can be excited by CXCL12. However, when we are using a medicine highlighted in red here, CXCR4 antagonist, we can actually block this connection and calm down the overfiring or hyperactivation of the receptor. So the mechanism of action of this medication is to bind to CXCR4 and block the binding its cognate ligand CXCL12. Therefore, we would then regulate the signaling and allow for the internalization of the receptor, which overall would improve the mobilization of stem cells and neutrophils from the bone marrow. So there are two medications that are currently trialed for WHIM syndrome. The first one that has been trialed for long is called Plerixafor, and it is an intravenous administration. Plerixafor is actually already approved to mobilize stem cells from the bone marrow in preparation of cancer patients for transplantation, and it has been trialed for WHIM syndrome, but not approved at this point. Mavorixafor is a CXCR4 antagonist that has oral administration and currently don't have FDA approval. However, there are several clinical trials. So here are some of the clinical trials that I located by using a search in clinicaltrial.gov. And I encourage you, if you're interested in treatments, to go to this website and repeatedly look for opportunities. Plerixafor was already trialed versus GCSF by the NIH. And this trial is completed and no data has been reported so far from the trial, but I'm very excited to hear about that. And there's an ongoing clinical trial by the NIH with Plerixafor for the treatment of WHIM syndrome. You can see that it is still recruiting and how to contact the investigators who are running this trial. And this trial is primarily for adults. Regarding Mavorixafor, there was a phase 2 clinical trial that just was completed last year. And this was a phase 2 clinical trial to look at the safety and efficacy of Mavorixafor and has been published now in Blood. So this is a publication that you can all read and try to understand if you think that this is something that you would be interested in pursuing, especially because there's an ongoing clinical trial on the efficacy and safety of the same medication that is still available. And I listed for you the sites that currently are recruiting for this study, including several sites in California, one site in Iowa, one in Maryland in our sister institution at Johns Hopkins, and Dr. Antoine Azar is the PI for that. We have a study in Texas and Washington State where Dr. David Dale, who is an expert of WHIM syndrome in this country, is running the trial. There's also an ongoing phase 1b clinical trial with Mavorixafor for patients who have severe congenital neutropenia, even if they don't have a confirmed WHIM syndrome. However, WHIM syndrome patients are eligible for this trial. This is a much shorter trial, and it has several sites in Iowa, Michigan, Missouri, New York, Ohio, and Washington State. And some of the sites are just coming on, and we would like to actually be a site for this study. So in summary, WHIM syndrome is a rare autosomal dominant primary immunodeficiency disorder with no approved targeted therapy. Patients with WHIM syndrome have pathogenic variants in the CXCR4 gene, which results in the retention of neutrophils in the bone marrow, and also lymphocytes and monocytes have problem moving around and doing their job. And this will lead to leukopenia and inadequate immune function. WHIM stands for warts, hypogam, infection, and myelokathexis. However, the acronym does not reflect the broad spectrum of the disease that the patient may experience. And we know that a clinical manifestation can be associated with significant morbidity and mortality, especially among those who face delay in diagnosis or misdiagnosis. Therefore, I'm really highly advocating for WHIM syndrome to be considered among individuals who have chronic neutropenia and myelokathexis, and they should go for and try to get sequencing done and confirm that the mutation is occurring in the CXCR4 gene. And as I mentioned to you, the current management is symptomatic only, which I think is not adequate to prevent serious complication and address the substantial burden of the disease. So I'm very excited about the new targeted therapy that's on research ground that may give us a better outcome at some point. There is a path forward genetic sequencing platform, which is free to patients, and X-Pharmaceutical has partnered with Invitae to offer you cost-effective and accurate confirmation of WHIM syndrome. The patients who are eligible have to have a neutropenia of less than 750 cells per microliter, and the panel can also analyze 407 total immune genes. So in case it's not WHIM syndrome, you can still have testing for additional neutropenia genes. I would like to thank some of our collaborators around the world who has been helping with our international study, and in particular the Jeffrey Model Foundation and X4 who helped us to investigate this syndrome further in pediatric patients and young adults. And without further slides, I'm ready for your questions and hope you find this helpful. Thank you.
Thank you, Dr. Walter. What wonderful information. And we do have a question here. And attendees, please feel free to send in additional questions through the Q&A box. The question is there any history of target therapy for WHIM patients?
So the last few slides of my talk is actually summarizing all the possible options for targeted therapy for WHIM patients. Some of the studies that have been completed now are partly published, like the Blood paper from 2020 on Mavorixafor. And also Dr. Phil Murphy, our NIH expert, has published several studies for WHIM syndrome and Plerixafor. So there's a lot of data out there, but at this point, we are not ready to recommend it on clinical grounds until all clinical trials are complete.
Thank you. Thank you. That's the only question we have received. So you must have covered everything. I sure learned a lot, and I cannot thank you enough for volunteering your time, Dr. Walter, to be with us today. And would like to thank everybody who joined this session, and also to let you know that I look forward in seeing you in the next session at 3:15, Swimming Upstream, Addressing Payer Challenges and Ensuring Access to Genetic Testing. So once again, thank you. Thank you, Dr. and attendees.
Thank you so much. Have a good day. Thanks. Bye.
Bye. Take care, everybody.